hearing to order. We're here this afternoon to examine critical programs within the U.S. Department of Health and Human Services that are also essential to upholding the federal government's trust responsibility for the health and well-being of Native communities, but that are not under the Indian Health Service. As we look broadly at the programs within HHS, we have to remember that for many Native communities, non-IHS programs are just as important as those under the IHS. From public health initiatives to social services, these programs often provide the only consistent access to basic supports for the most vulnerable members of Native communities. So, what programs are we talking about? It's Tribal Head Start that helps young children grow up healthy and rooted in culture. It's LIHEAP that ensures tribal elders have heat in the winter and air conditioning in the summer. These aren't just federal services, they're really critical components of the social safety net. And my view is that these programs support family stability, child development, and basic dignity. So today we're going to also hear about HHS programs like FIPSA, which is the Family Violence Prevention and Services Act. This is the primary federal funding stream supporting vital crisis services and shelters for those experiencing family violence. We'll also hear about how tribes are reducing the risk of costly intervention and foster care removals through child welfare services and tribal TANF. These programs help break intergenerational cycles of trauma, support safe housing, and equip Native families with the tools to thrive. Many tribes have built these effective programs over generations, investing their own resources, training their own workforce, so that they better align with their culture and community needs. These are models of local innovation and sovereignty, and they deserve both protection and sustained support. Given the scope and critical nature of these HHS programs, we're hearing growing concerns from tribes and Native communities about the executive order on optimizing the workforce across the federal government and the HHS announcements about reorganization and RIFs. I hear regularly from constituents that are asking, how do these proposals affect me and the delivery of essential services? I want to acknowledge and thank Senator Kennedy for recognizing the importance of IHS very early on. He made clear that they were not going to be subject to those RIFs. Now we're asking for the same understanding for other programs at HHS. And that starts with tribal consultation at HHS on these programs. I think it has to occur early, be consistent, and be meaningful. We know that when tribes are truly engaged in shaping the policies and programs that serve their citizens, outcomes improve, trust deepens, and federal resources are more effectively aligned with local priorities. These programs work best when they reflect the voices of the people that they're meant to serve. Forums like this hearing are also important. This is your opportunity to formally make your case for these programs to the legislative branch, but we also know that HHS will take notice too. I was in a hearing that began at 1:30 before the Help Committee, and Secretary Kennedy was there. I had alerted him that we were having this oversight, and he said if he wasn't in that hearing, he would be here as well, which I appreciate. And I think perhaps some of his team, if they're not here in the room, they might be watching or listening. So I think what we learned today, is not just going to be confined to this room, this audience, but broader. I want to thank all of you for traveling with us to be here today, or if you're here in DC, your journey is a little bit easier, but I know your time and expertise are invaluable. The insights that you share will help inform our continued work to strengthen federal programs and uphold the promises made to Native communities. So I'm looking forward to your testimonies. I now turn to Vice Chair Schatz for his comments.
Thank you, Chair Murkowski, and I want to extend a special warm aloha to Dr. Sheri-Ann Daniels, CEO of Papa'olo Lōkahi. Papa'olo Lōkahi is the sole entity responsible for coordinating Native Hawaiian healthcare services and is a leading voice for healthcare across the state of Hawaii. Mahalo for your continued leadership on behalf of Native Hawaiian people. Providing healthcare is one of the federal government's most fundamental trust and treaty responsibilities to American Indians, Native Hawaiians, and Alaska Natives. And delivering on that promise depends on over a dozen HHS agencies, not just the Indian Health Service. For Native Hawaiians in particular, HHS's trust responsibility extends far beyond just HRSA, but despite a lot of promises from the Secretary about strengthening Native healthcare and addressing longstanding issues, we've seen that this administration is engaging in staff layoffs, office closures, funding freezes, and proposed budget cuts that will undermine the quality of care and overwhelm a healthcare system that frankly is already on the brink. Excuse me. Native people are among the most vulnerable in health terms in the country, falling behind on almost every metric. They experience some of the highest rates of cancer, heart disease, respiratory illness, diabetes, overdose, and suicide, and their life expectancy is the lowest of any racial group in the United States and nearly 10 years below the national average. So the status quo was insufficient to begin with. Then came the sweeping cuts at CDC, NIH, HRSA, SAMHSA, ACF, and other offices and programs. A CDC team supporting overdose prevention in tribal communities was reduced from 7 staffers to a single human, who is now responsible for managing millions of dollars in funding. The Healthy Tribes program, which is focused on preventing certain chronic diseases, was gutted. 5 HHS regional offices, which served 461 tribes in 22 states, terminated staff and were abruptly closed in March. And all of this means that Native communities have less support for job training, child care, domestic violence victim services, suicide and substance abuse prevention, and much more. These cuts are being carried out without any tribal consultation whatsoever, in plain violation of our trust and treaty responsibilities. This is not just a moral question of what we owe Native people, it is also a question of the law. Let's be clear, the status quo was already insufficient. The administration's proposed cuts of nearly $1 billion to Native healthcare will make matters worse. There is bipartisan agreement on this committee that these communities need more help. Now is the time to stand together to protect Native healthcare. So I want to thank our witnesses, and I look forward to the hearing.
Thank you, Senator Schatz. We will now turn to the witnesses, and I'm going to turn to our colleague from South Dakota to do the first introduction.
Thank you, Madam Chair and Vice Chair. I want to thank you to our witnesses as well for taking the time to attend today's hearing and share your perspectives. Today, I am proud to introduce my friend, Chairwoman Janet Alkire of the Standing Rock Sioux Tribe. After retiring as a staff sergeant in the U.S. Air Force, Chairwoman Alkire returned home to serve the Standing Rock Sioux Tribe. During this time, she oversaw the daily operations of tribal government programs while serving 2 terms as the executive director. In 2021, Janet became the first woman ever elected by the people as chairwoman of the tribe. Chairwoman Alkire provides an important voice on several key tribal issues, including healthcare, public safety, and economic development. In recognition of her leadership and advocacy, Chairwoman Alkire was named one of USA Today's Women of the Year in 2025. Not bad. Congratulations. Matter of fact, congratulations. She continues to advocate for her people as a board member of the National Indian Health Board. I want to again thank Chairwoman Alkire and all of the other witnesses for attending today's hearing. Thank you, Madam Chair.
Thank you. I'll make full introductions of everyone, and then we will begin with individual statements. Following Chairman Alkire, we have the Honorable Loni Greninger. She is the Vice Chair of Jamestown. Is it Kalalam? Say it again. Sklallam. Sklallam Tribal Council from Sequim, Washington. We also have from Fairbanks, Alaska, Melissa Charlie. Melissa is currently the Executive Director of Fairbanks Native Association. She is a tribal citizen of Minto and has been involved in many, many leadership capacities in her region. She is focused and committed to early childhood development and community wellness, and really appreciate the fact that you've traveled so far to be with us, Melissa. Following Melissa, we have Lucy Simpson, the Executive Director for the National Indigenous Women's Resource Center from Lame Deer, Montana, as well as Dr. Sheri-Ann Daniels, who the Vice Chairman has already introduced. And if I'm just going to try to say it, as the Chief Executive Officer of the Papa'ola Lōkahi. Lōkahi? I have Papa'ola Lōkahi.
There you go.
Okay, from Honolulu. It's good for us to be working through the names and doing them correctly to show that respect. So I want to remind everyone that we do have your full testimony that each member has. We'd ask you to try to keep your comments to 5 minutes so that we can have questions following your statements. So Chairman Alkire, you may begin with your testimony.
Good afternoon, Chairwoman Murkowski, Ranking Member Schatz, and distinguished members of the committee. On behalf of the National Indian Health Board and the 574 sovereign federally recognized tribal nations we serve, thank you for this opportunity to provide testimony today. My name is Janet Alkire. I serve as the chairwoman of the Standing Rock Sioux tribe. I also serve as the Great Plains representative for the National Indian Health Board. I am Hunkpapa Lakota, a descendant of the Lakota leaders who signed the 1868 Fort Laramie Treaty. I'm a beneficiary of the treaty trust obligations enshrined in that agreement, which continue to shape the rights of our people and Indian country. The Department of Health and Human Services delivers vital programs to tribal nations and citizens. Forming part of the federal government's trust and treaty obligations, these services, many beyond Indian Health Service, are essential to the health and well-being of our citizens. As tribal leaders, we are deeply concerned about the ongoing HHS reorganization and its far-reaching consequences for serving tribal nations and their citizens. Despite chronic underfunding, tribal nations, tribal organizations, and urban Indian organizations rely on HHS resources to deliver life-saving care. Tribes have long supported efforts to streamline federal programs, reduce reporting burdens, and direct funding to the Indian health system. However, any reorganization must honor treaty and trust obligations, including meaningful consultation. We have urged HHS to hold consultations to ensure programs that serve tribal nations and citizens are protected. To date, the reorganization has reduced HHS staff by 24%, disrupting grant access, tribal advisory committees, and causing tribal program staff to leave. This has already resulted in the cancellation of over $6 million in grants, jeopardizing critical infrastructure for the Indian health system. The Great Plains is experiencing a syphilis epidemic, with rates among Native people rising to 1,865% from 2020 to 2022, 10 times the national average. The CDC played a key role in the response, but the recent restructuring cut nearly 20% of its staff, including those staff supporting our Tribal Epidemiology Center. OASH, Office of Infectious Disease, HIV/AIDS policy also lost staff, ending a program that awarded $16 million to 18 tribal and urban Indian organizations, improved HIV outcomes by over 90% at the Phoenix Medical Center. This leaves us without essential federal STI response support. Additionally, majority of the staff operating Healthy Tribes program under CDC, which oversees several grants, including Good Health, Wellness in Indian Country. Grantees are receiving conflicting information about their grants, and the programs are in limbo. One tribal grantee has already received notice of the termination. A UIO has reported losing communication with their project officer and grants manager, leaving a critical gap in their program. CDC's Division of Reproductive Health is a huge component for tracking maternal health and national outcomes nationwide, including Native moms. These staff were also placed on administrative leave and updates to the Pregnancy Risk Assessment Monitoring System, one of the few national data sources that tracks Native maternal and infant health disparities, has been paused. Because of this, we are losing vital tools for identifying risks, interventions, and saving lives. SAMHSA's Center for Mental Health Services has seen major staffing cuts Key tribal behavioral health grants have been terminated or left in limbo. Even when funding has been removed, temporary disruptions in funding can destabilize programs. The Great Plains Tribal Leaders Health Board's Connecting with Our Youth program, which applies traditional Lakota values to reduce youth suicide through mentorship and culturally grounded education, is at risk. This program reduced Native youth suicides in our area by 78% from 2019 to 2024. Successful outcomes like this shows what's at stake. In conclusion, programs serving tribal nations and their citizens have a minimal fiscal impact, but are foundational to improving chronic health conditions in Indian country. Tribes share a vision for a healthy America, but tribes must be consulted in the first instance. Tribes want to work with HHS, appreciate what the Secretary has done so far to protect our health. We want efficiency to reduce grant reporting, provide direct funding to tribes instead of reliance on state block grants, expand tribal self-governance outside the IHS. We must avoid new barriers such as DOGE, Defend the Spend, which increase burdens and withhold funding from programs serving tribes and its citizens. We can be the solution to a more efficient HHS. I thank the committee for this opportunity to provide this testimony. Wapila.
Thank you, Chairman. Next, we will go to Loni Greninger, the Vice Chair of the SCOLUM.
Yeah, Jamestown.
Let's call it Jamestown.
Yeah, thank you so much. Manu Ait Squatchy, Siam Styacha, honored leaders, Chair Murkowski, Vice Chair Schatz, thank you so much for the opportunity, and other members of the committee that I know are here. I'm grateful to their time as well. I want to acknowledge the opening comments that you said earlier. You're going to be hearing me repeat probably many of the things that both of you have said already. And for Vice Chair Schatz in particular, one of the things I've said at other tables before is I hate being the first place in everything like that. Chronic disease, all of these negative impacts, I hate being in first place. And I want to be able to fix that. And so that's one of the reasons why I'm here testifying before you today. So thank you for this opportunity. And for Chair Murkowski, I have family in the great state of Alaska, so I get to visit your great state often on the Kenai Peninsula. It's beautiful there. So I am the current vice chair of the Jamestown Squalum Tribe. We're located in Sequim, Washington, in the great state of Washington, and I serve currently as the ACF TAC chair. So I'm pretty intimate with the ACF programs and how those programs are being implemented on the ground, especially within my region and in my state and in my community. The Jamestown Squalum Tribe actually has a few of the ACF programs, so I get to see what those things are doing to my families in the most positive way possible. My service to my community comes by very honestly. I have 7 generations worth of tribal leadership in my blood, and all going from educational services to child welfare. So for me to be a social services director at my tribe for 5 years is one of my passions, and then I currently serve as the chair of a few different tables in Washington State as an Indian Policy Advisory Chair, serving not only just social services in maybe a traditional sense, but also corrections, Department of Corrections and Healthcare Authority as well. So I'm really glad to be able to be here to speak before you today. So in ancient times, we as tribes, we've had our own systems, so to speak, of how we addressed the community level needs, then the family level needs, and then of course the individual needs. And most of that was addressed in our ancient times through communal living and then also through spirituality, because we believed that mental health and emotional health, that was made whole through the spirituality. And so as the relationship between tribal governments and the United States was growing and it came to be, it was born, and it's evolved over decades and decades and decades, right? And so we've been learning how to evolve our systems. What does it mean to blend Western systems with our Indigenous perspective at the same time and being able to serve our people with these federal services? And so this is why we are here and testifying, is we are here to try and figure out how do we blend that all together. And you mentioned tribal consultation. That is essential to us figuring out how do we blend these systems together and make these programs work for us. How do we make these programs fit our cultural needs and then translate them into federal speak so that we can access federal funds? And so the huge concern of the rifts at HHS, as well as the proposed funding cuts, those are the things that are threatening our ability to be able to do that. These rifts happen without tribal consultation. The budget proposals happening without consultation. I have lost connections to my staff in Region 10 at ACF. That means TANF contacts. That means my ACF regional administrator, gone. Everybody's gone, and this was all done without consultation and with very little warning. not only to the tribes, but also to the staff. That also meant that we did not have any transition planning. There was nobody to tell us, hey, here's your next contact. For example, regions 1, 2, 5, 9, and 10 have been consolidated into, they've been eliminated, and now they're being consolidated into the rest of the 5. So me in Washington State, my new regional office is in Denver, Colorado. And when you eliminate all of Region 10, it's just talking about Region 10 by yourself, that's all of Alaska's more than 200 tribes. Washington's 29, Idaho's 5, Oregon's 9. That's 250 plus tribes that now Denver is absorbing into their portfolio. Do they know us? They don't know who we are. They don't know our lands. So we need to be able to have people on the ground who know our land, who know our intimate cultural nuances and our political nuances. And that's what these HHS staff members have been for us, the technical advisors. They help translate our language into your language so that we can access funds that are obligated to us through treaty and trust responsibility. As I conclude here with my remarks, one of the things that we want to see is just consultation. Consultation, consultation, consultation. We need HHS to understand the impacts that have already happened because of not having consultation. But we know that there are regulation decisions to come, budget decisions to come, deregulation decisions to come. And we need to make sure that tribal voices are at the forefront, that we have our voices heard, our impacts are heard, so that we can minimize impacts and we can maybe find some different creative solution that meets both the federal goal but also maintains trust and treaty responsibility for our tribes. In conclusion here, I do want to acknowledge that Secretary Kennedy, he seems to want to work with tribes, and I'm glad for that. He has advocated for Head Start for us, and we saw that in the president's latest draft of budget, so we're thankful for that. Thankful that LIHEAP is still also being chatted about as well. But we want to see more. It's more than IHS, right? You mentioned this earlier. HHS programs as a whole, even if the word tribe, Native American, or Indian isn't in the office name or in the grant name, it still serves tribes, and we want to be able to access that and make our communities healthy so we continue to blend those systems together, hopefully get us out of first place so that we can be healthy again. Thank you for the opportunity to speak before you today, and I'll look forward to any questions if you have any for me. Thank you.
Thank you very much. Well said. Melissa, welcome to the committee.
Good afternoon, Chair Murkowski and Vice Chair Schatz and members of the committee. Thank you for this opportunity to testify today. My name is Melissa Charlie, and I serve as the Executive Director of Fairbanks Native Association, FNA, a Native nonprofit organization serving the Alaska Native community since 1967. I'm here today not only on behalf of FNA, but also to uplift the critical importance of Tribal Head Start and other U.S. Department of Health and Human Service programs that serve Native communities nationwide. At FNA, our Tribal Head Start program is the foundation of our investment in early childhood development, cultural identity, and family stability. Our program offers not only education, but nourishment, cultural grounding, health, and intervention while offering a healthy foundation for families who need it the most. Our classrooms honor Native identity and language, instilling pride in our community while preparing children for academic success. For many families, Tribal Head Start is the first point of connection for a broader network of services that address health, nutrition, wellness, and family support. Moreover, our program, like many others, integrates traditional knowledge, language, and values into every single classroom. We know Tribal Head Start and child care programs across the country integrate various programs and grants to stretch every dollar and create a system of comprehensive community-based services. Many of these include utilizing Head Start with child care development funds or connecting programs with language work at the Administration for Native Americans. Indian country is the most dynamic investment that the federal government can make. FNA is no different. In addition to Head Start, FNA operates several other critical programs under HHS, including a youth and adult behavioral health treatment programs, which provide services that integrate Native cultural values and practices with evidence-based approach funding from SAMHSA. Child welfare, community-based family prevention, emergency youth shelter services, and family and domestic violence prevention and services under ACF. And we utilize funding under the current administration for community living, such as Administration on Aging Title VI funding, which fosters a healthy and connected elder community by providing nutrition, support services, and caregiver services. Yet, despite decades of success, Tribal Head Start and other programs remain under-resourced compared to other non-tribal counterparts. We face challenges recruiting and retaining qualified staff due to wage disparities. We need updated facilities, modern learning materials, and a more robust professional development, which requires an increase in stable federal investment and partnership with tribal organizations. Now is not the time to divest these programs. Now is the time to invest in Indian country, the same way the federal government hopes to reinvest in states. These programs work to form a safety net for our tribal families who too often exist in a gap where they remain underserved by state and local communities. Importantly, tribal programs like these are a direct impact for fulfilling trust and treaty obligations to tribes. In our area, the tribes and villages have done so through Native organizations like FNA. Whether a tribal nation or a Native organization, we are the best positioned to deliver these services because we understand our communities' histories, our strengths, and our needs. TANA Chiefs Conference, TCC, is our sister organization providing a large array of prevention and clinical services for the Alaska Native population across interior Alaska. Either in complement of FNA services or in collaboration with FNA, TCC, like FNA, relies on federal funding guaranteed under the federal government's trust obligation to Alaska Natives and American Indians, which requires the United States to protect tribal lands, assets, resources, and treaty rights, and to provide certain services such as healthcare, education, and housing. The federal trust obligation is not one that can simply be transferred to a state government. It is the legal and moral obligation of the federal government alone. For FNA, and in many tribes across the country, HHS programs are not simply support services. They are an act of a nation-to-nation partnership, upholding the federal trust responsibility to Native children, families, and communities. Today, I urge Congress to protect and maintain the Tribal Head Start program and other child care funding and support such a child care development funds, ensuring that these set-asides go directly to tribes or Native organizations and that they are not rerouted through the states. To protect SAMHSA funding for tribes like the Tribal Behavioral Health Grants and ACF programs, including by protecting administration for Native Americans through streamlined funding, which is directly provided to tribes and Native organizations. To support infrastructure investments so tribal providers can modernize facilities and expand reach. We stand ready to work with the administration and Congress to streamline and strengthen these programs with quality investments. Thank you for holding this important hearing and for your continued focus on the health and well-being of Native communities. I look forward to your questions. Bessie.
Thank you. Next, we turn to Lucy Simpson. Welcome.
There we go. Thank you, Madam Chair Makowski, Vice Chairman Schatz, and members of the committee for the opportunity to testify today on the critical role of HHS programs serving Indian country. My name is Lucy Simpson. I am a citizen of the Navajo Nation and the Executive Director of the National Indigenous Women's Resource Center. We are a Native-led nonprofit dedicated to restoring sovereignty and safety for Native women and families. We serve as the National Indian Resource Center addressing domestic violence and safety for Indian women, and the Tribal Safe Housing Capacity Building Center under the Family Violence Prevention and Services Act, or FVPSA. I first want to ground this testimony in what must remain the guiding principle of the federal government's work, its trust and treaty responsibility to tribal nations. This responsibility is not abstract. It is a legal and moral obligation. HHS plays a crucial role in fulfilling this obligation, not only by providing public health services through the Indian Health Service, but also in providing services that address the public health crisis that is violence against Native people. Congress reaffirmed this obligation in the Violence Against Women Act reauthorization of 2005, stating that Indian tribes require additional criminal justice and victim service resources to respond to violent assaults against women, and the unique legal relationship of the United States to Indian tribes creates a federal trust responsibility to assist tribal governments in safeguarding the lives of Indian women. By investing in tribal nations and Native-led organizations as they design and implement community-driven, culturally grounded services, HHS programs become instruments of tribal self-determination. Such programs include those funded by FVPSA, which for more than 40 years has been the cornerstone of our nation's response to family and domestic violence. It remains the only federal funding source specifically dedicated to emergency shelter and related services for victims and their children, and is especially important for tribal nations and American Indian, Alaska Native, and Native Hawaiian victims of violence. According to the National Institute of Justice, more than 4 in 5 American Indian and Alaska Native women have experienced violence in their lifetime, and more than half have experienced sexual violence and intimate partner violence. These statistics reflect a complex public health and safety crisis, which often involves jurisdictional confusion, a lack of law enforcement presence, geographic isolation, historical trauma, and distrust of systems. Yet despite the pervasive levels of violence, many tribal communities still lack access to the most basic safety services, with fewer than 60 Native-centered domestic violence shelters across all of Indian country. FIPSA provides essential funding to these tribal shelters, as well as counseling services, tribal domestic violence programs, the Strong Hearts Native Helpline, and resource centers like ours, all of which ensure that culturally appropriate services are available where they are most needed. But recent and abrupt changes within HHS, specifically the removal of experienced staff and leadership from agencies and programs that serve Indian country, threaten to destabilize the progress made. Sudden changes in leadership, staffing, and structure, especially without tribal consultation, can disrupt the continuity of services, erode trust, and delay funding for these life-saving programs. At a time when Native women face the highest rates of murder, rape, and abuse in the country, preserving institutional knowledge and maintaining stable, informed, and responsive leadership is not just a matter of continuity, it is a matter of life and death. Every day, we hear from frontline advocates who, with limited resources, are saving lives by creating safe homes, traditional healing circles, and language-based advocacy services that allow survivors to heal in ways that reflect their values and culture. When we invest in Native women, we invest in the future of tribal nations. We respectfully urge Congress and HHS to fulfill your trust and treaty obligations by prioritizing, strengthening, and expanding all programs that impact the health and safety of Native peoples, and for HHS to engage in meaningful government-to-government consultation with tribal nations before making changes to program structure, leadership, or funding. Thank you. Ahiahat.
Thank you. And finally, Dr. Sheri-Ann Daniels, welcome.
Velina Maikako, aloha Chairwoman Murkowski and Vice Chairman Schatz. Thank you for the introduction, and members of the committee. Thank you for inviting me today to provide remarks on behalf of Papa'olo Lōkahi, the Native Hawaiian Health Board. We appreciate the committee's legacy of strong bipartisanship in honoring the federal trust responsibility. And I'm honored to hear and learn from other Native American leaders and communities on this panel, because whose comments, stories, and challenges that they shared are what we face as well. Papa'olo Lōkahi was congressionally and statutorily created in 1988 to improve the health status of Native Hawaiians and the named entity in the Native Hawaiian Healthcare Improvement Act. So I want to be really clear, we are statutorily named and created to support and uplift the health of Native Hawaiians. And as the named entity, we have the statutory responsibility for the coordination, implementation, and updating of a comprehensive healthcare master plan, the identification and research of diseases, establishment of a network of health resources, services, and infrastructure through our 5-island community-based health organizations, as well as administer a scholarship for healthcare professionals. On the topic of this oversight hearing today, it is in our written testimony, we highlight the following key messages. Federal trust responsibility to Native Hawaiians are based on our unique political status, not on our race. So let me say that again, that there is a trust responsibility to Native Hawaiians, and that's through policy, funding, and consultative practices, which we often don't get. Our unique political status is recognized in other congressional acts, not just the Native Hawaiian Healthcare Improvement Act. And this is with a population that has grown 29% since between 2010 and 2020 census. That's huge. For almost 40 decades, Papa'olo Lōkahi continues fulfilling our statutory responsibility, including our Native Hawaiian health systems. We do this through funding with HHS. We talk about IHS, and you're correct that we do not get any funding through IHS. So the bulk of our funding comes from HHS through HRSA. And that fulfillment of the federal trust responsibility for Native Hawaiians are in the ways of programming and funding. And again, primarily through HRSA. The other HHS areas, including SAMHSA, we would be impacted through mental health and substance abuse, and we all know what those statistics are. In addition to that, we also currently are supporting the Lahaina wildfires impacted families. So over the last 2 years, over 12,000 families, 34,000 people, 3,700 professionals, boots on the ground, and over 140 organizations had a role in that and continue to have a role in that. We need to continue to focus on the most vulnerable of populations, programs that address the health, safety, and self-sufficiency of Native Hawaiian families, and that's CMS. Our Native Hawaiian population in Hawaii is 21%. Yet, for TANF families, 33% of them are Native Hawaiian. For victims of child abuse and neglect, 39.7%. Those are large numbers, greater than our population. The total Hawaiian population currently receiving Medicaid equals almost 77,000. That's a lot. 34% of them are children. That's not acceptable. If we talk about our cultural values and where we put our youngest as well as our oldest, that's culture. And when we remove those things, we create other impacts and other concerns down the line. CDC, the prevention services, tobacco, chronic conditions, we all know diabetes. Diabetes does not discriminate. It's no longer just a Native issue. So cutting those services have huge impacts. We also want to make sure we continue to advance the missing and murdered Native Hawaiian women and girls initiatives, but it's also with our tribal partners. We know that a quarter of the missing girls are Native Hawaiian. We also want to recognize the rurality of communities and the impact it has on health. That health policies should aim to reduce differences between rural and city areas. It is especially important because our Native communities, for many of us, tribes, everyone, our people live in rural areas, often with limited access to services. And finally, we need to continue to strengthen our networks. You know, in our written testimony, we highlight the Native Hawaiian Health Network collaborators across our 8 major islands. It's not just us. We recognize it's our Native Hawaiian health systems, our federally qualified health centers, our community health centers, hospitals, and especially our community-based organizations. We're doing it with everyone, linking arms. And I think that's important to recognize. And these are just some of the highlighted examples of the impacts that HHS in reduction and the things that are happening could have on our communities. And I look forward to answering any further questions from the committee. Mahalo.
Thank you very much, all of you. Appreciate your testimony and what you bring to the conversation here today. I want to start with tribal consultation because it's been mentioned by the chairwoman, Alkire, and Loni Greninger as well. I think all of you reference it, and again, we are seeing changes that are going on. I believe it was you, Chairwoman, that indicated that a letter had been sent urging tribal consultation in light of the reductions in staffing and the cuts. I am assuming that if there has been response to that initial consultations have yet not been made. Can you clarify for me where we are on that?
Yeah. I think I just want to say thank you to the ladies here also for, we come here to make these statements, and thank you, committee, for hearing what we have to say. But we know really what we have to say has to come from our heart. our people have always struggled with the fact of consultation. And I think, all our organizations, we send these letters, but we haven't heard anything yet. And I think that's the issue. And that's the issue I think all of America is dealing with. With all these issues that we have, these are saving lives. The consultation for tribal leaders and those involved with these grants that are receiving these grants and implementing these programs out in the rural communities, that's the voices that need to be told how important these programs save the lives for our people.
And that's why we're having this conversation with you, representing the many voices from your tribal communities, your regions. As I mentioned, Secretary Kennedy was before the Help Committee today, and it's very important for him to be there to be presenting the budget as we know it at this point in time. But this feedback is so necessary. We've talked about, we're seeing what is happening with the proposals for consolidation. The Administration for Healthy America will consolidate the Office of Assistant Secretary for Health, HRSA, SAMHSA, ATSDR, NIOSH, and so many of these agencies that are really very critical to the services that are provided to our tribal communities. So what I'm hearing is they are acting first. You're responding, saying, we need to know what is going on, and true consultation is not a responsive action. It is being there at the beginning so that some of this input, the imperative of Tribal Head Start, the imperative of FIPSA, the imperative of LIHEAP, that is factored in before the decisions are being made. And so I just want to make sure that for the record, what we're hearing from you as leaders in your respective areas is that outreach is yet to be had. Is that probably correct? I see everybody nodding their heads. Vice Chair Greninger, I want to ask, because you have great detailed insight into the ACF Tribal Advisory Committee, given your role there. Given the reduction of tribal engagement staff that we are seeing there at ACF, going from 5 to now just 2, and then the loss of the regional tribal program leads, what is this meaning on the ground for you? You mentioned the consolidation within the region, so Alaska, Washington, and some of the other impacted areas are now reporting into Denver. Just quickly, what's the impact of all of this? But what do you think is needed to restore effective tribal advisory functions during this reorganization? Because we've got a reorganization going on. It's just pretty public here. Tribal advisory role is pretty key. How do we make this more effective?
Ooh, those are great questions. So the effect of what we're seeing now with the RIFs, those particular 5 advisory staff that you're talking about come from the ACYF within ACF. So they were the ones that were actually helping ACF leadership wide be able to understand tribal nuances. What does it take for us to participate in grants? It was also helpful in the consultation setting where we could help form agendas together, make it a collaborative process rather than just it's a one-sided federal process. Consultation is both of us coming together, right? So with the RIFs of those particular staff, what's walking out the door is tribal nuance knowledge, institutional knowledge, and then intimacy with the tribes. So all of that, all of the advisory is walking out the door, unfortunately. So we are left behind with staff who maybe have minimal knowledge or no knowledge, and they're learning it as they go, and it takes a long time to understand tribes. So that's one of the areas that I have a huge concern about. But what can it take in the meantime? Gosh, if we could get those staff back. I don't know what process that would take, but if we can get those particular staff back, that would be wonderful. And having the consultation process, maybe ACF specifically with tribes, HHS broadly with tribes, each branch of HHS with tribes, so we can dig into those particular programs and those nuances, that's going to be most helpful because we've lost those advisory staff.
So I know I'm over my time, but I think this is a question that my colleagues would agree is worth drilling down on, because the Secretary has said to individuals within HHS that have been terminated, that if they so desire, they can move over within the IHS sphere. Does that make sense? Or are you talking about levels of expertise where a body just isn't a body?
That's a great question. I would be concerned that IHS becomes all things Indian for HHS, because IHS is strictly about health. When HHS programs and tribes, it's all HHS offices. So I need expertise in each branch of HHS.
Very good, thank you. Vice Chair.
Thank you, Chair Murkowski. And it occurs to me, obviously you're the chair and you can tell us how to work together on a bipartisan basis, but it seems to me this hearing is calling for some follow-up and using the convening authority of the Senate Committee on Indian Affairs, because nobody's talking to anybody. And I think it should start, there are lots of, we could suppose how things might work better, and we might have some pretty good ideas, but it sort of starts with you knowing who to call and that person having any authority or knowledge at all. And well, so it's, I'm not a believer of just get everybody into a room and it's going to work out, but I do think that's probably a necessary condition for success, that we start to have a dialogue and know who our points of contact are and kind of what the path forward is. And I commit to you, Chair, that we'll try to do that. I do my fair share of partisan fighting. This is not the place for that, and I'll try to make sure that we keep it on the substance of the matters. So thank you for your leadership here. Dr. Daniels, welcome. Lōkahi is authorized to coordinate healthcare programs and services for Native Hawaiians, subcontracting with Native Hawaiian and community health organizations. Are there any other entities authorized to do this work under the statute? No other entities. Thank you.
Sorry, no other entities.
So as the only entity coordinating care for Native Hawaiians across the state, what is your service population and what happens if HRSA's funding gets cut?
So our service population is targeting Native Hawaiians, although because we get federal dollars, we cannot limit access. So it is community. Just in our 5 Native Hawaiian healthcare systems, we're serving over 70,000 individuals, touch points. That's clinical, non-clinical, that's outreach. We know in our communities, face-to-face, going out to where they're at, that's what we know we have to do. Traditional practices, all of those things roll up into those numbers. That does not include our network partners. So it's not just the 5 systems. PAPA actually reaches out and we contract with other FQHCs. So we recognize we can't be the do-all and be-all, that our community doesn't only see one type of provider. And so reaching out to the FQHCs, our community health centers, our hospital and institutions, we're creating bridges, we're partnering with them, but also our community-based organizations across the state. So adding those numbers in, those touch points grow. And we know that that's how our community gets help and accesses care. And to adjust that to already be fearful about cuts in funding, people are scared and nervous, and having those reach outs allow us to, one, keep a pulse on what's happening with our community so that we can report back, but also then we can get the stories, which we did provide in our written testimony from communities in all different areas.
Thank you. Everyone is tracking that there's a House bill that will cut Medicaid by about $700 billion. There are carve-outs for Alaska Native and Indian tribes. there are no carve-outs for Papa or for Native Hawaiian health, and I'm wondering if you could speak to the impact of Medicaid cuts for Native Hawaiians.
Well, good question, Senator. And I want to say this because I think at one comment was we speak from our heart. The fact that there's an exclusion of Native Hawaiians is unacceptable. That should stir something in all of us, that we talk about being Native communities, yet we exclude. And that's not acceptable. And so just at the offshoot, the exclusion of Native Hawaiians in that House carve-out, it perpetuates the belief that within departments and agencies that we do not exist. And I'm sure some of our other tribal communities might feel that way, these moments of not existing. And we cannot perpetuate that. But I think the biggest piece is in imposing these new hurdles, that's what I'm gonna call them, it's just that, they're hurdles. They impact eligibility, they slow access to identification of needs, they slow access to services. We don't need any more slowdowns. And specifically, if you talk about the work requirements, employment is one of the social determinants of health. And if we're talking these things, we're saying these things, all of this adds to our community and the people we work with. Native Hawaiian employment rates are amongst the lowest in our state, and you couple that with the highest health disparities. Doesn't look good, it doesn't fit. And so basically health plus employment are seen as separate issues, and they're not. They're tied in together. Employment equals health, and health equals employment.
Thank you. And I just, there are a lot of very valid complaints about the healthcare system. I have never met a single soul who has asked for more paperwork. And that's a lot of what the House bill does.
So Senator Lujan was actually here first, but he just kind of walked in. If you want to catch your breath and let Senator Smith go.
Well, thank you, Chair Murkowski and Vice Chair Schatz for this hearing today, and thank you so much to all of you for being here and for providing your testimony. I think that now is a very good time to be talking about HHS programs and how they should be benefiting Native people as part of our trust and treaty responsibilities, and to acknowledge that what the Trump administration is doing, what Secretary Kennedy is doing and gutting and reorganizing the department is directly hurting communities, Native communities in this process. And, I think it's so ironic because during his confirmation process, Secretary Kennedy talked a lot about being a champion for Native people. He talked about his own father. He worked hard to build his reputation for being a leader who was going to keep Native people in his minds, but yet in his role so far, I think the reality has been very different. And I am really struck by the stunning lack of consultation that you all have described in your testimony. And again, we all know here that that tribal consultation is not an optional thing to do because it's nice to do. It is part of our legal trust and treaty responsibilities, recognizing your sovereign nation status. To do that. So whether it comes to suicide prevention or HIV prevention or ICWA or elder programs, all of these are vital to the health and well-being of Native communities. And God knows IHS needs reform and improvement and more funding. But to be clear, that is not all that we're talking about here. And so I'm grateful for this hearing and the opportunity to talk about this, because I think in many cases, I know from the nations that I represent in Minnesota, that these are issues of life or death. And have such direct consequences on what happens to people in their lives. So I want to follow up. I appreciated very much the question that Senator Murkowski, Chair Murkowski snuck in at the end of her. I want to just follow up on that. There's been this information about how senior career officials who are like, tobacco regulators, research scientists, and others at NIH, as those jobs are being eliminated, have been offered jobs in, far-flung locations in IHS. And as I was reading this, I found this offensive. So you have individuals who don't have, these are clinical jobs for the most part, I think, and that these clinical jobs would be offered to be filled where we already have such a great shortage of staff and people with folks that don't have clinical experience. And so I want to just ask any witness if you could comment on this, what impact do you see this has, and how do you view this from your perspective? So I just open that up to anybody. Yeah. Chair Alkire, would you like to take this?
Yes. In preparation for coming here, all of us ladies here, we all have an area, but one of the things in my regard was to talk to our CEO at our IHS facility and talk about, the impact that it's had in regards to staffing and the loss of providers. And I'm glad that Secretary Kennedy is going ahead and letting up a little bit on the hiring freeze, but it's not, it needs to be across the board, especially for, those types of providers that we need and to provide that health care. The staffing is so important for these facilities. I mean, it's even like if we can't even hire a maintenance janitor, that means the hospital is not safe. These kind of basic, these basic things. So, I think all the ladies could agree on that. There's huge need. When you're...
And sending sending a research scientist who specializes in like tobacco cessation research to an IHS facility when what's needed is not research but clinical care doesn't really solve any problem, does it? Yeah.
May I?
Yes, please.
I think one thing that we also need to remember is when we're eliminating researchers, tribal researchers in particular, now we're talking about another historical issue of concern where research has been used against tribes and in unethical ways it's been implemented in our communities. So if we're going to be eliminating positions of research that have that tribal nuance and that knowledge.
That's right. It's kind of a double whammy.
Absolutely. And the nexus for like programs in ACF, I've actually, in this last budget consultation last month with HHS, I was wondering, how can I make a better connection between NIH and ACF programs? Because data is huge. That is a huge issue for us. Child welfare data, especially when we have children in the state systems and in our own systems. So to hear that those particular positions were also being eliminated, just because I'm not in NIH intimately, doesn't mean I'm not concerned and I don't see the connection to other programs across HHS and my tribal community.
Thank you very much. Thank you very much. Chair Murkowski.
Well, thank you, sir. Gentlemen, thank you, Madam Chairwoman. Can I jump back, Dr. Janis? I want to touch on something that you were in a conversation you were engaging with Senator Schatz, FQHCs. Medicaid funding to FQHCs is in jeopardy, and if they don't get their funding, they could close their doors. And most people don't realize in Nevada we have 28 federally recognized tribal communities. Not every one of my tribal communities has a health center. They just can't afford it. They just can't do it. So they rely on FQHCs. And sometimes those FQHCs are a 2-hour drive for them. So we're not just, a carve out, which we talked about, is not enough. It is really important that we provide a system of health care for our tribal communities, indigenous communities, that they can not only access, that's reliable, that's affordable, right? And so can you talk a little bit about these Medicaid cuts? It's not just the impact to tribal communities themselves, but surrounding communities where there's a system of health care that could be devastated, particularly in our rural communities. If you would touch on that.
Absolutely. And I think you brought up a very good point that it's just not the Medicaid, because if FQHCs or others are impacted, it also includes the retention and recruitment of staff, but then they can't, we have several FQHCs that are in high rural areas that they supplement housing for those providers. We have one island that access to it is on little 9-seater planes, and providers are coming in. Those things are all going to be impacted. So then it goes, where do our community go? Off island, where we already have health deserts. I mean, not the same way as I think South Dakota, but similar. Yeah, we have a water between the islands, but when pregnant women can't give birth on their islands, how does that? And so we already now are eliminating another access point.
That's right.
That's a challenge. The one thing that we recognize is the network. So I think oftentimes FQHCs and other health entities are siloed, right? We do what we do in our community, and that's it. And we have recognized that we no longer can do that, that resources go down, that we're going to need each other and to support and pool our resources so we can continue to serve our community. But when those keep getting like pinged off, it's really hard to keep doing that. And then our communities grow and our providers don't grow, right? There's still only a handful, but the number that's coming grows. So I think it's all of these domino effects when we start taking off, and it might seem very minimal that we're going to adjust or take off of Medicaid on things, but then we might not see it today or tomorrow, but we're going to see it as people start having to close, and not even, close doors, but close services. Maybe they're not doing the 5 types of services, maybe it's only 2. And that becomes a problem. And for us, then we start looking at, if that service isn't provided on their island, where do they go? And do they have access to pay for a $200 ticket to fly to the next island?
Right. And it's the same. Listen, it's the same in rural communities as well. I know, listen, in Nevada, sometimes you have to drive 4 hours just to get access to healthcare. That's if you have a car and if you get off work to be able to access it. So it is a system that will shut down.
Yes.
That is essential for providing healthcare that, quite honestly, you've worked so hard to put together because of a lack of resources and a lack of providers and a lack of really geography that brings everybody together like you have in an urban area. So I appreciate this. I want to touch on, my time is running out. Mental health. I cannot stress this enough. I am so concerned about the cuts to mental health services that we fought for in our communities. There is a program called Native Connections, and I know about it because in my state, I have talked with so many of my Native community members. There's a 9-year-old girl in Nevada Urban Indians who was struggling with mental health, and she could not get the care from a school or a pediatrician, but it was Native Connections program that, according to her father, got his daughter back. It's a Native Connections program. And so I don't know if any of you are familiar with it or if you could talk about it, but please stress the importance of why funding for programs, particularly in this mental health and Native Connections, is so important.
Okay, thank you. I'm so glad you brought that up. So it is clear to me that programs like Native Connections save lives, and thank you for that. And for my tribal community, last week, 2 suicide ideations happened with a 5th and 6th grader. These programs are so important right now to save lives, right? So suicide rates for Native youth are 4 times higher than any other racial or ethnic group. Native Connections allows awardees to tailor culturally appropriate programming to reduce suicide, substance use, and impact of trauma in tribal communities. Native Connections empowers Native youth by strengthening community ties and providing, as I said, culturally responsive support. Through this program, youth engage in models that promote through protective factors like personal wellness and positive self-image and a strong sense of cultural identity. Without this funding, intervention and support services for Native youth will become even more limited. This puts Native youth, many of whom experience discrimination, trauma, and loss of loved ones, at greater risk for resources available for them to heal. So I think it's so important, it's life-saving. So thank you for that question.
Thank you. Thank you, thank you, Madam Chairwoman.
Thank you, Madam Chair. And thank you and to Vice Chair Schatz for this important hearing. To each of our honorable and distinguished witnesses, thank you for taking time to be here, away from other responsibilities and especially from home. I know that this is not easy. Madam Chair, before I begin, being more aware that Secretary Kennedy would have liked to have been here and that his staff may be here or may be watching. I want to point out what a disappointment I believe this administration has been to the Indian Health Services. Recently, when Secretary Kennedy was in Window Rock, Arizona, and in Gallup, New Mexico, he was just minutes away from one of the oldest IHS centers in Gallup, New Mexico. If he would have gone there, he would have seen this. What it says is, do not drink the water. Do not use the water for consumption. Failure to follow this advisory could result in illness. Do not use the ice, and then in quotes, made from tap water, for drinking and patient care. Don't use it for baby formula, for brushing teeth, for making ice, care until further notice. The way that I was raised is you make time for what's important. And he didn't make time. The other thing I would share with Secretary Kennedy is it's been over 60 days that members of the United States Senate sent you a letter about the measles outbreak in America, where many of our constituents are not just sick, but some have died. Respond to the letter. Keep your word. When you were asked in committee if you would respond to letters sent by members of the United States Senate, you took an oath and said yes. Keep your word. I'm just very disappointed there. Ms. Charlie, as an alum of Head Start, I'm one of only two in the United States Senate that went to Head Start. I often joke, I thought everybody went to Head Start. I don't know, you had to be poor enough to go. I believe in early childhood education. I believe the United States Senate, this is a place that Head Start can get you, in addition to other responsibilities we have around the world. Research has demonstrated that high-quality early childhood education programs increase child educational achievement later in life and significantly reduce the livelihood of adult poverty. Right now, there's conversations taking place about going after one program or another. There's statements on social media that are later redacted and things of that nature. What can you share with us about the importance of early childhood education and programs like Head Start to the livelihoods of kids and others that you're honored to represent and speak for?
Well, Head Start is critical for the kids that we serve. At FNA, we serve 224 kids. We provide interventions. We work with the school district with the special education department. We do the 45, 90 days dental health screenings. We provide referrals with healthcare and other specialists needed. So we provide an early intervention for the kids, so when they get into school, they're not delayed. The school doesn't have the capacity to do what we do. They don't even screen for our IEPs till third grade. They don't have the capacity to provide the services that we do at Head Start. So it's critical. It provides a structure for them. It develops routines for them, and so they're ready when they get into school. And not only that, it supports the whole family. Our program supports grandparents come in and volunteer. We're culturally based. We do a lot of cultural activities. We created a book with Danaka lesson plans. We were working on a digital app to give access to that to anybody who wanted it. So it's important, and the school just doesn't have the capacity or resources to do what we do.
I appreciate that strong testimony. Now, I would argue all of us on this dais, including those that are not present right now, we all care greatly for Native American mothers and for babies, which is why I'm outraged by the fact that 92% of Native American women that die from pregnancy-related deaths are considered preventable. You know, just let that sit for a second. And that the CDC has seen a 20% reduction in staffing, leaving more vulnerabilities out there. This could be all preventable. Honorable Alkire, can you speak to how the reduction in force at IHHS and reorganization in programs like the Pregnancy Risk Assessment Monitoring System will have on people going forward, namely moms and babies? Yeah, so in the area of maternal health,
Yes.
with moms and especially with babies, with looking at 92% of those that we lose, it's all preventable.
Right.
And there are more conversations around programs like the Pregnancy Risk Assessment Monitoring System getting financial support or not. Some of the layoffs at HHS. Do you have any thoughts there of taking those programs away or making it harder? What kind of impact would that have on moms and babies?
Yes, actually, there's several, and we provide a lot of this in the testimony because this is such an important issue for us. The investments from HRSA, this is one of the conversations I had with the CEO in regards to young moms at, where I come from. She said the issue is that a lot of them, these programs fill the gaps because IHS does provide services, but these programs that HHS provides, they fill the gaps for a lot of our tribes with these grants. And one of them is to help young moms get some prenatal care, get some education, because the issue, I think, in having such as scary statistics that we have is that a lot of these are young moms and they don't come to the hospital until they're like gonna have the baby. So a lot of them need this education. They need these programs, these grants that are out there, provide that connection for them to learn what is coming that way, even to see the baby's growth. And that way it provides more of a connection for the mom to see how important it is to take care of themselves and take care of the baby. That's what these grants provide. So HRSA's investment in Healthy Start saves lives. By supporting tribally tailored programs, it helps reduce infant mortality and address adverse perinatal conditions in American Indian and Alaska Native populations. Healthy Start is a vital lifeline for rural and remote communities. It provides essential services like health screenings, nurse visits, and support through tribal home visiting programs, which I think is so important right there, to ensure new and expecting mothers receive the care they need. Programs like this help bring knowledgeable staff into our communities so expecting mothers and new moms do not have to drive, as we said, 3 or 4 hours away to get support for pre- and postnatal care. Without HRSA funding, the tribal maternal and health safety net is at risk. Losing these dedicated resources would weaken critical support for Native families at a time when these services are essential more than ever. Many young mothers, as I said, don't show up until they're ready to have their baby, so perinatal care is often not even sought. This program puts babies on the radar so home visits can be conducted, and as I said, it helps connect them. These programs are successful of collaboration and also culturally appropriate programs because I think it just helps with identity issues for the mother and the baby and just the family. So
Thank you.
super important.
And Madam Chair, just in closing, thank you for your leadership, for putting a face on the people across the country that we're so honored to represent. and for fighting for them. More of that is what we need, and just want to say thank you to you and to Vice Chair Schatz for that. Thank you.
Thank you, Senator Lujan. Significant issues that we're talking about: maternal mortality, just how we are able to ensure that the programs that are so important for, again, so many that are so vulnerable. We've talked about mental health. I want to talk about domestic violence for just a moment. This was a matter that I raised with the Secretary at the hearing at 1:30, and I mentioned FIPSA. This is the primary federal funding source for our domestic violence shelters and our support services in our tribal communities. Obviously essential for emergency shelter crisis intervention, and we understand all too well up north why these are priorities. I received a letter back, it was dated April 2nd from the Alaska Native Women's Resource Center about the impacts of the layoffs at the FIPSA office, the concerns about what it means to have the director of that office placed on administrative leave, and I'm going to enter this into the record, as well as an attached letter that was directed to Secretary Kennedy about the same subject. When I mentioned this to the Secretary, he indicated his clear support for making sure that when it comes to domestic violence, shelters for women and the most vulnerable, that it is not his intention to be cutting programs. And I don't recall his words specifically, but it was something along the lines of he didn't think that they had cut programs. But I also recognize that in budgets that are proposed, that's one thing. But sometimes you can effectively eliminate the effectiveness of a program if you don't have people there, right? If there's nobody there to process the grant application, if there's nobody there to answer the phone or to respond to your email about what the status of your grant is. So let me direct this one to you, Ms. Simpson. Can you describe how the Office of Family Violence and Prevention has been key in implementing FIPSA in our tribal communities? And then what happens when you don't have, okay, let's just say the program is still there, but you don't have the folks to implement it. What happens to those you're trying to serve?
Well, thank you for the question. The Office on Family Violence Prevention Services, we call it OFIPS. The OFIPS office, under former Director Dawson's leadership, has been instrumental in reorganizing, recognizing the need for culturally grounded and Native-led programs for survivors of violence. And the OFIPS office ensures that over 230 tribes and tribal domestic violence programs receive FIPSA formula grants that allows them to provide emergency shelter and crisis intervention services. OFIPS also partners with Native-led organizations like NIWRC to provide training and technical assistance and resources to tribal grantees and advocates that can build the capacity of tribal organizations so that our communities have access to long-term and specialized care that meets their unique needs. And in this way, OFIPS helps to carry out the federal trust obligation. When the Director Dawson was abruptly placed on administrative leave, not only did that impact the office's ability to move forward, but that was felt all the way down to the individual tribal grantees. There was a significant gap of communication, silence between program officers and the tribal programs in terms of what this was going to mean for ongoing funding. There were uncertainty. There's a lot of uncertainty from grantees because none of the new solicitations have gone out. No new the continuation applications that normally are released in March haven't been released yet, so programs are unsure what the funding's going to be. So it's good to hear that Secretary Kennedy has assured that those programs will maintain funding, but that hasn't been expressed to any of the programs yet. There's a lot of questions about what is now allowable and what is not allowable. That information that we haven't gotten guidance, tribal programs haven't gotten guidance yet, so it's caused many programs to kind of feel a need to halt services because they're worried that they might do something wrong and then lose their funding and get their grants terminated the way things have happened at Department of Justice. So it creates a lot of uncertainty and stress and fear within these tribal programs. The substantial reductions in force will, if there are more, it'll surely interrupt the essential functions of these prevention efforts across Indian country. These rifts threaten decades of improvements in the public health response. Tribal programs rely on OFIP staff who have cultivated trusted relationships with the tribal nations, and this can take years to build. The institutional knowledge is immense. This long-term relationship building has also led to many OFIP staff developing cultural competence, significant cultural competence, trauma-informed expertise, and a deep understanding of the complex realities that face our Native communities. So when we lose those staff, when we lose the communication with those staff, then we're resulting in gaps of silence and tribes unable to be able to move forward with their domestic violence programming. So it's pretty significant. Also, I think that the loss of leadership is a direct result of that is the funding delays that tribes have experienced. It results in many programs where the possibility of being forced to shut down or lay off staff, and we do know that there have been programs that have had to lay off staff because of the long gap in receiving their funding through drawdowns, as well as the uncertainty of being able to maintain funding into the future.
We've heard some of that where the uncertainty with the funding coming, let's just say it's been put on a pause or a freeze or just the uncertainty. And in so many of these, with so many of these programs, if you've got a shelter that you're trying to run, usually you don't have a lot of cushion. You're able to pay your staff for salaries that month and maybe the following month. You're able to get the food, the supplies for maybe that month, maybe the following, but there's not a lot of again, cushion in the event that these funds don't come through. And if you can't provide the services, you can't open the doors and you can't provide the safety that is sought. Ms. Charlie, I know that there at FNA, you utilize the FIPSA funding to help those that you serve in doing everything from temporary housing and safety for survivors. So I'm going to ask you a question that kind of ties into FIPSA, but goes just a little bit more, because I mentioned the issue of LIHEAP, the low-income heating and energy assistance. This is a program that has been zeroed out for us in Alaska. It makes a difference. You need to stay warm in the winter. I would imagine that in some of the areas that you represent, it's about air conditioning in the summer in order for your elders to be safe in their own homes. One of the things that we have heard is that the assumption with this proposed budget was that with a greater focus on energy production, it would lower the cost of energy to people's homes, and so thus the LIHEAP assistance would not be necessary. That may be true in the future. I don't know that we've got an easy button on this to reduce energy costs around the country, much less in a place that is as expensive as Alaska or Hawaii. But Melissa, if you can just share for the committee record the expense that a family basically faces in staying warm in a place like Fairbanks, Alaska, and what it would mean if if you weren't able to access this LIHEAP funding?
Well, like you said, the cost of living in Fairbanks in Alaska is extremely high. There's places in Alaska that 1 gallon of heating fuel can run from $5 to anywhere over $10 a gallon, and that's for heating fuel. We we do have an elders program. We do a lot of case management. We do deal with a lot of elders who not only have food insecurity, but can't pay their energy bill. They can't pay their rent. And so this is the case management that we provide. And we also do it with the FISPA funds for emergency shelter, because as women leave a domestic violence situation with just the clothes on their back, they can't afford the temporary housing, not in Fairbanks and especially in remote Alaska. And so it's really critical. For the energy assistance, it's a huge impact on all of the families we serve, not just the elders, but the families in Head Start. The cost of living in Fairbanks is extremely high, and the surrounding areas is much higher. So it would be devastating to everybody we serve across all of our programs.
Thank you. Senator Lujan, do you have follow-on questions? Okay. And I'm just going to keep going here for just a few more minutes. Because I think one of the things that we share as members of this committee when we think about the many challenges that we see across Indian country and the barriers to things like economic opportunities and strong education is the issue of mental health, behavioral health, and the lack of services that are then made available. We've had a little bit of conversation about some of the statistics related to suicide, and I agree with you, Vice Chair Greninger. We are tired of being number one in so many of these really awful statistics. So SAMHSA's Center for Mental Health Services has faced pretty significant rifts. And now with this proposed elimination of SAMHSA overall, I'd like to hear from you about the impacts on the delivery of culturally responsive programs to tribal communities. Either one of you, yeah. Go ahead, yeah. I mean, obviously it's an important issue.
Great, thank you for the question. So SAMHSA is important in particular because when you look at SAMHSA mental health programs compared to IHS programs, IHS does have mental health dollars, but it's focused on adult mental health, and SAMHSA has children and family mental health. So that's where it's super critical for us tribes to be able to have those dollars so that we can specifically tailor our mental health to our children and our young families. So I would highlight Circles of Care is one of those particular programs. The other great thing about SAMHSA mental health programs is tribes don't have to compete for them. In other programs, we have to, which is really sad for us. We hate competing against our brothers and sister nations. So those are the two biggest things, to be able to focus on youth and the non-competitiveness of SAMHSA. So the ability for us to even have culturally relevant services, that kind of flexibility within SAMHSA grants is what allows us to get to that spirituality piece that I was talking about in my comments, where we can bring in the songs and the language, and we're filling in that emotional and spiritual piece of the holes in our hearts that, frankly, medical care from the Western perspective cannot touch. So that's why we are always going after those dollars, bringing in drum making kits, bringing in regalia making kits, teaching our kids language, bringing in the language teachers. Like, that's all part of mental health, as well as doing, I'm going to say, more traditional forms of treatment, such as, counseling and things like that. That's all essential too. But bringing in those spiritual healers as well to teach us the songs and to help heal our hearts and spirits in that way. Those SAMHSA dollars can help us in those ways as well.
But important point about not having to compete, which is significant. Dr. Daniels, you look like you were.
I was.
Get in there.
Yeah, you mentioned the Center of Excellence, and I think we all have part of that. So at PAPA, we actually are a pass-through with the state for the Center of Excellence, and ours is called the Ohana Center of Excellence, which is an NHPI Center of Excellence. And what has been happening is with the rifts and the changes, that program has been asked to scrub the information that they've put on for communities to access. So things around webinars or culturally appropriate programming that goes onto those websites are at risk. And so our communities cannot access it. And it's just not those community, it's the professionals that are working within those communities that it is a TA type of opportunity for them. And so though that center of excellence is at risk. And then also our SAMHSA also funds emergency, the surge, which is the Lahaina wildfire disaster monies. Same thing, that those kinds of opportunities to get creative and really focus in on communities are being kind of shifted off. And so I think I agree with the SAMHSA kind of understanding and how they support communities.
You know, as I think part of what we were hoping to accomplish today was, again, to remind not only those in the administration, but just to remind all of us of the many, many programs that are available that are critically important to Native people, whether you're in Hawaii, Alaska, or elsewhere around the country, that are outside of the IHS system. And we've talked about SAMHSA, we talked about young people, early Head Start. We really haven't had that much of a discussion about elders. And clearly, the Older Americans Act, well, it doesn't say anything about Natives in the title, but clearly those programs or those services, whether it's the congregate meal services, the caregiver support, these are vitally important. And I don't know, I know Melissa, probably FNA does a fair amount with the Title VI, the tribal program there within the Older Americans Act. Do you want to speak to how important these programs are for our elders?
Yes. So at FNA, we do have an elders program at community service. We do receive Title VI funding. We provide 800 meals a month, Monday through Friday. And we also help assist with food boxes. They have a garden for food insecurity. And we serve over 300 elders in our program. We do a lot of case management if they can't pay their rent, if they can't pay their fuel bill. But what I really love about our elders program is like they're really integrated in everything that we do at FNA. They are at the school tanning moose hide. They are at our Head Start program, teaching them how to make fry bread and cook berries. They are at certain schools that they are the grandparents for certain classrooms, and they are teaching them how to jig. They're doing songs and dance. They are just really involved in everything that we do at FNA. I really love that program because, you know, it's important that we take care of our elders. We're all going to be elders one day. And so it's really an amazing program. They love their program. They love to come together and congregate and eat and just be together. Otherwise, they'd be home alone. And so every time we invite them to talk at our annual meeting, they're there, they're speaking, and they own their program. They develop their agendas and meetings and topics that they want to do. And it's just, it's a really amazing program, and it really builds, it makes them happy to be able to come together.
I love the fact that they're there with the kids as well. I want to ask a question about efficiency, because we're operating in an administration that has taken a very keen eye towards efficiency, and we all know that we can and should do more when it comes to more efficient operations. And so I think we have something to advertise when we're talking about the 477 program. I look at that as a model for tribal self-governance. It really demonstrates how tribes can exercise their sovereign authority. It's the integration of employment, of training, of human services into one just efficient, streamlined plan. So I think this is probably directed to you, Vice Chair Greninger, about how, I guess, the progress that we've made over the years in expanding HHS program participation in Tribal 477 plans, and how important you think it could be in this administration, again, one that is really keenly focused on how we can do a better job in reducing inefficiencies, in eliminating kind of the overlap and the overlay. If we've got multiple programs here, consolidation is good. Let's make sure we're consulting on it all. Let's make sure it makes sense. But talk a little bit for the committee here about the value of the Tribal 477 program.
Absolutely. Thank you for the question. So I think I'm going to steal the words from my chairman, Ron Allen. He said, if there's anyone who understands how to run things efficiently, it's the tribes, because we are all wearing multiple hats, smaller governments, and trying to stretch the dollar as far and wide as possible. So 477 is really critical to tribes because it allows us the flexibility to self-govern. We can take these funds from the federal government and we can issue them into our community the ways that we see fit. The other important part of that is, we're talking about efficiency, is the reporting structures. Data and reporting is much more streamlined. It's a reduced burden for us, especially the smaller tribes such as Jamestown. Now, we aren't 477 per se, but we will advocate for it. I'm more of a 638 tribe. But when we talk about like HHS programs in particular, we have been working with ACF specifically to increase those particular programs. What we would love to see is if all of HHS programs and ACF programs could be in 477 because of that streamline factor, and it gives us that self-governance benefit. ACF has worked with us, and I think we're up to about five programs in 477. I would like to highlight for this committee that there are going to have to be conversations to talk about the barriers, probably with some of like regulations and maybe part of like the statutory pieces of this. Like with Head Start, we've had some concerns about that. Head Start was able to be put into 477, but there was discussions on, are we meeting statutory requirements when we put Head Start under 477, when we're releasing some of these data burdens, reporting burdens, statutory burdens, health and safety burdens, things like that. But I think that those are conversations that tribes want to have. And if there is statutory requirements we need to look at and evaluate those, I think those conversations should be happening. So we're hoping that HHS would remain open to adding more programs into 477.
So let me ask on that. Do you think, or is it, maybe it's too early to know whether there is somebody within a HHS that is dedicated, I guess, to be able to support tribes in integrating these HHS programs into their 477 plans?
I think I'll need to follow up with you on. I want to say that ACF has a couple, I think maybe two or three staff that are dedicated to 477 right now. But I can follow up with you on that.
Well, the reason I ask, and I think the vice chair noted it at the beginning of his questions, or maybe it was the end of them, that this input that we're getting from you today is really important, that it be an iterative process, that it not just be this conversation today, but that we build on this, that as you're bringing information to us, we're able to feed that up, to let them know it's going to be really important that you have somebody within your department that is tasked to these things, and then further, that individual that has been named, you all know who is on point there. We can be that intermediary, but it shouldn't be for more than just the fact of getting a name and then being able to pass that on. So I think it is going to be important, again, that we are working with the folks at HHS, the folks in the Secretary's office, in recognizing and acknowledging the many, many, many programs within HHS that have implications for our tribal and our tribal citizens and Native people. And so how we do this going forward, we're going to kind of rely on those of you, the many that you represent. There is still much that is going on within this reorganization that we are all just learning about. I mean, the fact that we don't have yet a full president's budget, we just have a skinny budget. We're operating off of a continuing resolution, and we're hoping that the departments are going to be following their operational plan, and if not, that there's reprogramming. There's just so much that is just uncertain. And I think the message that I would like to leave with all of you is amidst this uncertainty, know that we've all got to kind of link arms and get through this together. Even though the frustration at times may be really hard to deal with because you can't seemingly get answers. And I know we want to try to give benefit of the doubt as administrations are getting stood up. We are very, very slow in moving these nominations through the floor. It is a process. It could be made easier, but we are where we are. And so you may be the secretary that is accountable, but you might not have your full teams in place to do the execution, to do the kind of consultation that I think we are talking about, that you need and demand, and rightly demand. So I'm not making excuses for the administration. They've got to answer on their own. But I do know that the secretary has indicated to me that these matters are priorities to him. We want to take him at his word for that, and that he will assign teams that work with us to better the lives of our Native peoples wherever they may be. So I'm really appreciative for what you've brought here today. If there are additional matters that the committee needs, I know that questions for the record will continue to come in, and we'd ask you to try to help us out with that. I started off my morning with the administrator of the EPA, and we were asking him about various grants that have been paused or frozen or still under review. And I just told him that we would like a list. We want to know from your perspective where things are, because if something's been terminated, that's one thing. If something is still under review, that's another thing. Maybe you can hold on and keep your folks on at your shelter for another month if you know that there's still a likelihood that that funding's going to come through. But if it's been terminated, then decisions are being made for you. So if you have specifics that you want to share with us that we can then elevate, know that we also can perform that role as well. So thank you to each of you for making the trip, and thank you for the leadership that you provide respectively. And with that, the committee stands adjourned.